Thank you everyone for joining us tonight. I see that there are attendees from all over Canada, all over the US. It's so exciting, and I really appreciate you being here tonight. I would like to disclose that I'm receiving an honorarium from SDI, and I thank them for their support and their really amazing products. I'm a 97 graduate of the University of Michigan School of Dentistry. I did a GPR after dental school. I am an accredited member of the AACD, a COI Center graduate, and last summer I got my mastership in the AGD. My hobbies include running, traveling, and photography. All of the photographs in this webinar are pictures that I've taken, with the exception of maybe two SEM photos. But to the right here are pictures from my trip to Amsterdam last week. Just got back on Friday. And if you've ever been, it's actually a really lovely place to visit in the summer. One particular place of interest to me was the Royal Delft factory in a small town outside of Amsterdam called Delft. And we visited because I was really interested in seeing this factory where they produce the very, very traditional Dutch ceramic ware that is blue and white, and it's very characteristic of the country. So you can see the building on the right and then the actual factory on the left. And I thought it was fascinating because I felt a connection between this factory and just, dentistry and what we do in dentistry. And in the back there on the left picture, you could see the ovens that they use to fire and glaze the ceramics. And then on the right, you can see that there's just 4 stages of the ceramic ware. It starts off and then they hand paint it and then fire and glaze, and then it ends up with that blue and white color on the right there. So it was so cool because they had someone on site kind of hand painting, and we were able to watch. They've done it this way for years and years and years. They tried to do it with a digital painting robot, and the results were suboptimal. So they went back to hand painting. So the reason I felt such a connection with this place was this was all about, to me, craftsmanship, which again is work that's done by hand. And the final product is just stunning. It's so similar to what we do. And they had these little signs that I thought were intriguing. This one said, when translated, everything is done by hand and people are amazed. So drawing that likeness to dentistry, I feel that composite dentistry is our skill and our craft. It's our craftsmanship. And it's just amazing that we get to be able to do that and express that with our chosen profession. And over the years, manufacturers have made it easier and easier for us to work with composite. Kind of the latest buzzword has been universal, referring to universal adhesives and universal composite systems that have been made to be simplified so that it's easier for us to get a really nice final result. So tonight, I'd like to just go over adhesion, adhesives, and then the latest in composites, clinical indications, and a few of my cases. So starting off with adhesion and adhesives, I'm sure this is going to take you back to dental school, and I'm sure it's something that you already know. But just to touch on this, again, adhesion involves the micromechanical and chemical bond of monomers into enamel and dentin, into the porosities of enamel and into dentin tubules. And so the whole goal is to form this hybridized zone or hybridized layer. And we want to mimic the bond that's found in nature between enamel and dentin at the DEJ. So the naturally occurring bond between enamel and dentin is over 50 megapascals, which I was blown away by that number. The minimal clinically acceptable bond strength between enamel and resin is 19 megapascals. So we know that adhesion to enamel is very different from adhesion to dentin. And the reason being, enamel is 95% mineralized tissue. It's hard, and the rods are formed from ameloblasts. And we know that etching with phosphoric acid followed by adhesive yields the highest enamel bond strengths. Dentin, however, is very different. It's only 50% mineralized tissue, 30% protein matrix of mostly a collagenous matrix, and then of course water. And dentin, the collagen degrades with exposure to phosphoric acid etch when it's as strong as 37%. So the etch that we use for enamel should be different from the etch that we use for dentin. But we also have to deal with this smear layer that's formed when we prepare dentin. We know that when we cut dentin, that smear layer forms and could inhibit our adhesion. So again, enamel bonding for years and years has been very predictable, and it begins with acid etching with a 37% phosphoric acid for approximately 15 to 20 seconds. When we use a self-etch system, which we'll talk about shortly, self-etch systems are not recommended for uncut enamel. And again, with dentin bonding, it involves the management of that smear layer, once again, which forms after we prepare tooth with a burr. And that debris from preparation can block and occlude the dentin tubule orifices and get in the way of our adhesion systems. So the smear layer, once again, decreases the permeability of dentin. And one little note is that if you use a diamond burr on a slow speed, after using a carbide burr, that may reduce the smear layer and increase the opening of the dentin tubules. So methods of adhesion, and something that we use probably every single day. It's either a total etch system, a selective etch system, or a self-etch system, and we'll cover all three. So a total etch adhesive system, this term was coined years and years ago when the first and second generation bonding agents were out, and it refers to the application of acid etch to both the enamel and dentin simultaneously. It removes the smear layer and increases dentin tubule permeability, but there's a separate primer and adhesive, so essentially three separate steps. The primer wets and penetrates the collagen, and then the adhesive permeates the prime dentin to form that hybridized zone that we talked about. With a self-etch adhesive system, it contains a weaker built-in acidic monomer than the total etch does. It's incorporated into the system, so you don't do a separate etch step, and it incorporates the smear layer into the hybridized zone instead of removing it altogether. And this incorporation allows for less post-op sensitivity because those fibers don't collapse as they do with total etch. There are, however, weaker bond strengths at enamel margins than with total etch as well. So again, in my office for years and years, we've always had two bottle systems. The left OptiBond FL as a total etch system, and then the right is a Clearfill SE as our self-etch system. And then if we wanted to do kind of other adjunct things such as a porcelain repair, or try to bond to porcelain or an alloy, we'd have to use a separate bottle and a separate step. And then moving on to selective etch. So selective etch refers to etching the enamel first with acid etch, followed by a self-etching dentin, or etching the enamel a little longer than the dentin. But there are higher enamel bond strengths than self-etch alone, and we can selectively demineralize that dentin. And so this method offers the benefits of both systems, both the total etch and the self-etch system, and is my preferred method. So the latest addition to our armamentarium of adhesives are the 8th generation or universal adhesives. And the benefits of these adhesives is that they're very versatile. They're compatible with whichever protocol that you want to use, whether you use total etch, self-etch, selective etch. And the key piece is that there's incorporation of 10-MDP monomer that helps to form bonds to calcium. And amazingly, one bottle can bond to various substrates, including glass, zirconia, metals, and resins without using that extra priming step or a separate bottle. The great thing is that this really simplifies the inventory, and of course, the confusion that you may have when you're trying to figure out which substrates to use for which particular material. One key point is that MMPs, matrix metalloproteinases, are enzymes that can, in the hybrid layer, degrade the collagen, and then long-term could affect the adhesive of restoration. So we need more studies with universal adhesives and MMP activities. One tip again is if you have chlorhexidine in the office, if you use that after etching, it could inhibit the MMPs. A study came out recently by Dr. Koop and Dr. Blatz, the selective enamel etch technique. And the highlights of this article, they basically say that the acid etching of dentin could result once again in the exposure and degradation of that dentinal collagenous matrix. And that exposure could increase MMP activity, which could then degrade the hybrid layer over time. So they are suggesting a reduction in the etching time and exposure to the acid etch to the dentin. So that could reduce the MMP activity. So in essence, a mild universal adhesive with a selective enamel etch only and rinse is what they advise. So SDI manufactures a really nice 8th generation universal adhesive called Zip Bond. And the nice thing is that it does have the MDP monomer in it. It is BPA and HEMA free. It's got really nice wetting capabilities. What I like is that it's clear, and when you cure it, it doesn't change any of the value or chroma or just a shade of the tooth that sometimes adhesives can. So it's a nice little tool to have for interior restorations, and it works well, and it's effective with both a total etch, selective etch, and a self etch. This was a page from Dental Advisor, and they ranked Zip-On as a 4.5 out of 5 stars, just with the versatility and the ease of use and its ability to decrease post-op sensitivity. I'm going to share that with you. So now in my office, we absolutely have a universal adhesive on hand at all times. We've got our multi-bottle systems, but over time, I think that we will start to really minimize our collection of adhesives and maybe hone it down to 1 or 2. But for now, we definitely have Zip-On as part of that protocol. So let's stop for a moment. And Lisa, if you could run this poll and ask the audience, are you using a universal adhesive in your practice? All right, I think yep, wow, fabulous. We've got 80% of our audience using a universal adhesive already, and about 20% that haven't yet. Great. All right, so moving on to composite resins. Again, there's a pretty little vase that they painted in the Royal Delft factory. All right, so let's do our breakdown of composites. So we've got a whole slew of composites that we have available for us to use in everyday practice. And the great part is that there's so many that can be intermixed and used in sandwich techniques and things like that. So again, back to the basics, composites have a resin matrix. So a matrix of organic monomers that combine to form chains and polymers. And then there are inorganic filler particles such as silica, glass, or quartz, which increase the strength and hardness and wear of that resin matrix. Along with that, composite has silane coupling agents and pigments and stabilizers and initiators and such. Traditionally, composites were classified by filler size. And as we know, there's microfills, which are about 35 to 40% filled, and 0.02 to 0.04 microns. And then we've got microhybrids. Before the nanohybrids came out, we had microhybrids, so they were about 70 to 80% filled. And then there's a mix kind of small and large particles, so 0.04 microns, and then bigger ones that are 1 to 5 micron particles. And then we've got our nanofills, which are just nanoclusters, more homogeneous, but about 5 to 75 nanometer particles. Coming back to our microfill, it's something that I have to have in my office because I love using it as a top layer for my chairside composite veneers. It's radiolucent. It's, as we know, not for use on load-bearing or stress-bearing areas where there's occlusion, and approximately 90 megapascals of flexural strength. So the lowest of our choices. But the amazing thing is that there's such a high luster, beautiful polish that you can get from having a microfill over top of your restorations. And it's something that I think should be a part of your armamentarium if you haven't already started to use this. Our microfill is one of my favorites. It's kind of what they call like a modern microfill. It's got some of the properties of a nanohybrid composite, but still that's amazing polishability that you can get when you put it on top. Next is our microhybrids. So in the past, when we had about 20 shades of composites that we needed to have, we had a whole spectrum of translucent to somewhat opaque to very opaque. Microhybrids were kind of in the middle, and our dentin body shades were mostly microhybrids. So again, a mix of smaller and larger particles and 155 megapascals in flexural strength. So pretty nice strength and acceptable for our load-bearing sites, and much more chromatic than microfills. And then lastly, of course, our nanofills or nanoclusters, very opaque, about 130 megapascals on average of flexural strength, and acceptable for load-bearing areas. The great piece of this is that this is what I would consider a universal composite, suitable for all over the place. There's a nice balance of polishability and strength, and it's great for just single shade restorations. Luna 2 is SDI's latest nano composite, and there's a nice spectrum of shades and comes in both the syringe and the compules. And then, of course, bulk fills. So bulk fills can be placed, as you know, in bigger increments than traditional composites. They're more translucent, so it allows for more light transmittance, and you can put it in there, but little chunks of 2 millimeters at a time if you need. Great for amalgam replacement and as a sandwich layer. And then very magical composite is flowable composite. I love it, and it's so great because it's just there as a rescue composite. You can fill those voids. It's great for implant provisionals. I like to use it right above my acrylic part of temporary implant provisional. And then I do a lot of fiber reinforced splints in my office for interim restorations. So flowable works great there. And then I use it as kind of a binding layer between my chairside composite veneer layers. So if I start off, I'll do the first layer of traditional composite, and then I use a flowable to kind of bind the next layer. And then, of course, I line my posterior restorations with flowable composites as well. And we've all heard of and are probably starting to do some injection molding too. So now we can use that as part of our toolkit. Glass ionomers and resin reinforced glass ionomers, great for sandwich layers. Again, terrific for geriatric and pediatric patients, and they're bioactive. So it's so amazing because you could have someone with pulpal inflammation, and if you can bring out the glass ionomer and use it as an interim restoration, it may really help calm the tooth down and decrease symptoms that the patient might be having. So how do we use composite? So many ways. With a matrix, with injection molding, just freehand, which I have a bad habit of doing. And then, of course, we can use it in layers with the putty stent, and we have a more intricate or complicated case. So what I usually start off when I'm looking to restore a case in my office, I ask, how many different composites will I use for this? And how will I place this composite? How will it be held together? And I go from there. So traditional resin systems, again, had multiple shades, and we used to have to stock, just about every shade in case we needed it. And then they would expire, and there's all those shades that you hardly ever use that just kind of sit around. We had varying opacities and translucencies. We'd have an enamel shade that's translucent, and then a more opaque shade, like a dentin shade, we called it, and then an in-between body shade. So nowadays we have the more simplified resin systems with a much smaller condensed palette of shades. And there's even now universal composites that are just one single shade that manufacturers say can serve all of your composite needs. And by the way, this little polar bear here was carved over 100 years ago. I just thought it was fantastic because it looks so modern and it's monolithic. So very cool, kind of like our zirconia nowadays. This artist was ahead of his time. So a simplified example of a simplified resin system is Aura Easy. So you can see in this little graphic here, AE1. So there's only 4 shades, and each one of those is compatible and acceptable for use with different parts of the Vita Shade Guide. But you can see AE1 could work as a B1 and an A1, all the way to like AE4, which is useful for A3.5, B4, C3s, and kind of that part of the Vita Shade Guide. So very cool. We'll stop again and ask our audience, Lisa, if we could do a poll question. Do you routinely use a simplified or universal single shade composite? And we'll give you a few seconds. All right, we've got 68% using a simplified system of some sort and 32% not yet. Always fascinated by what we are all doing. Perfect. Coming back to kind of my resin decision tree, how many different resins will I use for a restoration? So 4 options here, going from 1 single shade to 2 to 3 to 4 or more. So a single shade nanohybrid is what I'll pull out if I know that I'm just gonna do one shade and I'm done. A nanohybrid is my option. If I'm gonna do 2 shades, I'll try to mimic the dentin layer and then an enamel layer on top. Still pretty simplified. And then 3 shades, of course, if we want to do something a little more intricate, a palatal layer, oftentimes it's a clear shade, an incisal, or what's called clear occlusal is my palatal layer. And then my dentin body layer, and then enamel layer over top. And then if we are able to plan out a case and we're doing chairside composite veneers and we're doing 6 to 10 of those, then we'll go ahead and do something much more complicated. We'll do our palatal layer, a dentin body layer, along with our tints and opaquers as we need it, and then enamel layer, and then whatever flowable resin that we need as well. So using this little decision tree, we start off by asking, what does the adjacent tooth look like? And how will I recreate what's there in the adjacent tooth, or what does the patient actually want? In a case like this, you see there's just a lot going on there, but it's a small fracture. Coming back to how to decide, our enamel layer actually modifies the value of the tooth. The dentin layer is the actual shade. So the dentin determines 95% of tooth color versus just about 5% the enamel does, which really, again, it's just the modification of the value of the tooth. So that possible 0.5 millimeter of your recreated enamel layer might change the value, but it's not going to really change your shade. In my office, I have Aura Enamel Microfill, and it comes in 3 different shades. So, and this is something, just in general with microfills you want to take a look at. Is it chromatic or achromatic? So in this particular system, E1 is meant for more like young bleach teeth, lighter, brighter. It has a high opalescence, low translucency, and it's designed to mimic young enamel. Versus E2, which is a little more neutral in color, lower in opalescence, and just kind of an intermediate translucency, designed to replace more adult enamel. And then, of course, E3, which is has a more yellow-gray value to it, higher translucency, and meant to kind of recreate aged enamel. So my ideal resin kit would have a microfill in it. And if I were to choose Aura, then it would be E1 and E2 shades. I don't have the need for E3 very often. And then a nanohybrid. So an A1, A2, B1, definitely a bleach shade, and then an incisal shade, more of a kind of a clear, but still a nanohybrid for that palatal layer. And then I might want to have a simplified system where I have the flexibility for those darker shades that I don't use very often. So instead of having 5 to 6 of those shades, like the C4s, the D3s, the D2s, all those, I would have just 2 syringes of maybe the AE3 and then the AE4. And then flowable, which I love, and is just so versatile, amazing. I'm definitely at least an A2 and a B1 for when I need it. And then our opacers and tints that we like. In my office, I have like a lavender and then a gray tint. And then I have a pink opaque and a white opaque, which come in very handy. So then the question becomes, how will you actually place the composite? Are you going to do it freehand, which I'm often tempted to do, and especially if we're in a hurry, and if you're in a PPO office, you just want to kind of get productive and get done, and you'll freehand your composite, and that's that. And your patient is happier long before you are usually, so it works really well. Next is with a matrix, of course. If we want a nice, smooth mylar finish, then we certainly want to use a matrix, especially if the gingival third is involved. And then we move on to using a putty stent with a matrix. And then lastly, in injection molding. So we'll kind of go through each of these scenarios. So freehand, again, small fractures, diastema closures. Yes, I've done a lot of freehanded diastema closures over the years, and small class 4s. And again, when you don't have time for a matrix or a stent, you just get in there and get it going. You'll freehand your composite. So let's take a look at a case now. So you always want to, of course, get a feel for what the patient wants. Do we want to recreate the demineralized or hypocalcified areas, or are they just interested in fixing the repair and moving on with it? So this patient just wanted to get it fixed. And, again, with something like this, I would use a microhybrid or a nanohybrid, and the whole process is very quick and we're done. So this next case is a patient who presented with aesthetic concerns about her front teeth, but she couldn't afford to spend a lot. And, this stage in her life, she was a student and she just wanted to get something better than what she had. She wanted it to be improved, but she couldn't afford to do ceramic veneers or chairside composite veneers. So she said, I want to do some bonding and I want it to look better. And I'm sure we've all been in this situation where they say, can you make it look better? But I can't afford to do anything big right now. So, do what you can do. And so you're limited. And with a case like this, we could easily kind of think about doing freehand single shade nanofill composite. And in her case, that's what we did. Here's our lateral smile view on both before and after. You can see that there's a whole lot less splotchiness, and we were able to cover up that hypocalcified enamel. So she was thrilled with this. Here's our smiling after and retracted shot again. So we were able to just really change a whole lot of the smile design parameters with 2 visits. Hour and a half for the first visit. We bonded the 6 teeth, and then I like to always have them back because I want to improve upon what I've done and try to get the most polished surface that I can get. And so 30-minute second appointment. And we were able to do quite a bit with just that one composite, the one nanofill. We corrected her cant. We improved symmetry, and we've got a much more harmonious, balanced smile, a more proportionate smile. The laterals are not so small, and just overall brighter, and she was thrilled with the result. So what about when we actually need to layer? So we've all had these class 4s come in when patients have had trauma from years ago when they were younger, and over time they start to really discolor. And in this case for him, he has a class 4, but this restoration was also trying to kind of cover up that the tiny midline diastema that's there. You can see that the composite extends over to reach the adjacent tooth. But again, looking at this case, looking at the adjacent tooth, there is some translucency here. So I wouldn't want to just put a single layer nanohybrid for this situation. I would want to be able to layer a bit and allow some of that natural kind of opalescence and translucence come through. So for this particular case, this happens to be my class 4 accreditation case, actually. So I thought you might like to see this. Again, back to our resin restoration decision tree. Single shade, one composite, usually monochromatic, nanohybrid. Wouldn't want to do that with him. Two shades we could do. We could just do a dentin body layer and an enamel layer. We don't have a lot of room to put, many layers, but we could potentially also do a palatal layer with a clear occlusal or an incisal, and then move into a dentin body layer and then enamel layer over top. And we don't have room to do a whole lot of tints opaquers and things like that. So with this case, we could either go with option 2, again, enamel and dentin, or option 3, 3 shades, palatal layer, dentin body layer, and then enamel layer over top. And so here's our after. This is, again, my accreditation case. It passed accreditation. It took a couple visits because I was trying really hard to get this to blend in seamlessly. But needless to say, the patient was really thrilled. And, comparing the before and the after, we did a little bit of resin bonding on number 9 as well to balance out the width to length ratios and not have number 8 lean over so far to close that diastema. It's kind of like a combination diastema closure and class 4. I think this case is probably about 8 or 9 years old right now. So anyhow, moving on to matrices. I really feel that we need more matrices in the market, and I'm always looking for something new to kind of aid and assist my composite dentistry. We've got metal matrices, which we've all used. We've got the sectional matrices, which I use for both posterior and anterior. I like to use the sectional matrices to help with the distal contour of anterior teeth. I think it gives a really nice shape. And then, of course, for class 2s and large MODs in the posterior. And then we have our plastic sectional matrices. We've got our mylar strips that we have, and then of course there's BioClear. And the great part of it is that you can cure through it, and you get a really super duper smooth mylar finish that you often don't have to touch, especially at the junction of the gingiva and the tooth. So that gives us just a much healthier long-term tissue response when you're not polishing at the gingiva. And then lastly, of course, we can injection mold into these into the BioClear matrices to close black triangles, and I'll show you a case here shortly. So again, this patient presented and said she was not happy with her smile, but really she was not happy with just the giant black triangle between 8 and 9. And she said, let's start there and I'll think about the rest another time, because she hadn't had any bonding before, so she wasn't really sure how this would turn out. So we decided to use a BioClear matrix, so we had a nice smooth mylar finish at the gingival, but also a nice emergence profile. And here's our after picture with a smile and then retracted. And then here, so this was immediately post-op. We did it in about 25 minutes, and we used a single layer of nanohybrid. We used the Luna B1, and I actually injected this without warming it. Kind of, my assistant and I just kind of jumping right into it. And after the fact, I was like, we probably should have warmed that, but the Luna just flowed so nicely, and you could see that the seams or the margins are very, very well kind of hidden there, and you can't really see where the composites stops and the tooth starts. So that's just amazing to me that this composite has a chameleon effect and kind of take on what's there. So moving on to a more complex case, and this is one that you might have seen before, but just a whole lot going on here. She was very young when she first presented, and she's got a lot of tissue display at rest, and she was very unhappy with just her short square teeth. So there was a lot of work to do before we can get to this stage of actually restoring her. She did not want to do ceramic. She only wanted to do composite resin. So we phased this out. We did some transitional bonding at first, And then when she was a little bit older, we moved on to doing osseous recontouring with the periodontist, and because she wanted bigger teeth. And then from there, we eventually did 10 chairside composite veneers. So again, treatment plan was osseous recontouring, chairside composite veneers. And so with her, of course, we want to use option 4. We want to layer with the putty matrix for our palatal stent, as you can see here in yellow in this picture. And then for the gingival portion, we use matrices to shape and get a nice mylar finish. So with a case like this, I like to use a full contour matrix, either plastic or metal. If you've ever seen the Unica for anterior matrices, they're nice. I think they work well with a wedge, and they're meant to be the whole way around the free gingival margin there to get the shape. And then there's, of course, plastic full contour. There used to be a strip called the Contour Strip by Aviclar. They unfortunately no longer make it. It's one of my favorites. And then my friend and mentor, Marshall HandsOn, now has his own matrix system, which is fantastic. Again, you might need to do wedges, or one thing I really like to do is secure the matrix around into the gingival sulcus, and then use some unfilled resin on the outside to secure that so that it doesn't move around. Then, of course, there's just the flat mylar matrices that we have in the office. So here's our case after. Again, with her, we did multiple layers and tints and opaquers and things like that. So just a huge difference from where we started to where we finished. And there she is after. And she got the bigger teeth that she wanted, and she also wanted a very, very bright bleach shade. Here's a picture and the website for Marshall HandsOn's matrix system as well. He does phenomenal chairside composite veneers. I think that he is, in my opinion, a composite master. Just gets that amazing finish. And his secret to just the very symmetric shapes that you see is this matrix system that he developed. So it's amazing how he's just consistent with every case, and he gets these ideal proportions. So something to check out if you have a moment. I think this kit would give you enough matrices for a very, very long time. Okay, and then lastly, injection molding. With injection molding, of course, you need to really pre-plan this case. You need to have, case planning with the patient, and a wax up is absolutely mandatory. Whether you're doing a digital or an analog wax up, it's something that you have to have. And then if you're working with a technician, they can kind of do your models for you and make it just a lot easier. But it's with the use of a clear silicone stent and a high strength flowable composite. So I personally like to use injection molding for mandibular anterior teeth, especially if I'm restoring the upper anterior. I don't like to do ceramics on mandibular anterior teeth. It's just a pet peeve I have. I just feel like it's so destructive to remove. They're tiny teeth to begin with, and when you're prepping, you're taking away. So I love that you can add with injection molding, especially if you're opening the vertical, for an OBD. Because this case was one where we opened the vertical, and we had the ceramist. We did upper ceramics, and then on the mandibular, we went ahead and did injection molding. The great part is that, again, there's minimal polishing of the body of the restoration, and it's conservative and relatively easy once you start doing it. And the hard part is just managing, figuring out how you're going to manage the gingival third, if you're going to use a matrix or if you're going to tuck a cord in there. And then certainly if you want to do effects and tints and opaquers and things like that, you'd have to injection mold and then cut back and then place the effects, and then kind of just hand stack that final layer. So there's always a time and place for it. So here's a case that I'm actually currently doing. It's a case in progress, but I thought it would be kind of nice to share with you what I did about a week and a half ago. So this patient, and we're all looking at this thinking, oh my goodness, it's really, really challenging. And someone tried to work with this patient years ago. She had two crowns on 8 and 9, and then she eventually did veneers on 7 and 10. But over the years, the gingiva receded, and she didn't address the remaining teeth. So just a lot going on, just overwhelming. So I wanted to share with you that we bleached her initially, and then here's just a quick video of we decided. So here was a treatment plan we were going to do, and this is something that the patient really had a lot of input on. She did not want to prep the premolars. She felt that she had already had restorations put on 4 of the anterior teeth, and she was okay to extend that to 6 anterior ceramic restorations from 6 through 11. But she felt very strongly about doing composites if we could on the remaining premolars, and then eventually she'll do the mandibular teeth. But so this is our treatment plan for now. We did 4 premolar chairside veneers, and then 6 anterior restorations. I don't have an after for you because we're in progress, but hopefully in a future webinar I can share with you. Just a quick video though. This is using injection molding using LunaFlow. So you can see that we got the matrix from the ceramist, and then we decided to do the injection molding before we prepared the 6 anterior teeth. But it's just a really nice option to have. We did put down, we tried a couple different opacers. The white opaque was too bright and we could see the transition. So we had to go back, take it off, and we went ahead and used pink opaque, which really made a difference. And then it was a much, much smoother transition. So here's her immediate post-op. I snapped a photo to share with you. But if you come back, in the very back is number 3, number 4, number 5. Number 5 is the chairside composite veneer. And then 6 through 11 were the acrylic provisionals. So you can see just a dramatic improvement with absolutely no preparation on number 5. So she was thrilled, and I was very happy that we could, effectively mask that color. So the provisionals here, of course, you can see the tetracycline staining through the acrylic, and we're going to go ahead and do ultra translucent zirconia at the recommendation of the ceramist. Okay, we'll stop for a second before we wrap up. Poll question: are you doing injection molding in your practice? Here we go. Wow. Okay, 12% of you are doing injection molding, and 88% of you are not doing injection molding. I wonder if you might consider it now after this webinar. But there's definitely a learning curve, but it's a nice skill to have just for those times when you think that you might want to injection mold, like the case that we just showed you. Wrapping this all up, composite dentistry to me is craftsmanship, and all of dentistry is, but when you're kind of hand stacking and using your dexterity to do this, it really is a craft, and it takes time and patience and the right materials to get your kind of final finished product. And we're all in a different stage with this. There are people that I think are composite masters, and then there's all of us that are just kind of learning as we go, and each case that we do teaches us something new. So I think it's amazing that we have this craft in our profession, and I find it to be very, very gratifying when I can do a composite that the patient is happy with. We're finished in just a couple of visits, and they're happy with the result. And again, one of these little sayings from the Delft factory, it actually said, it's very difficult to make small work look beautiful. And all of the work that we do, I feel, is small. It's macro. So I think that we should all feel really proud of our profession and our craft, because we do some amazing things every single day. So Wanted to quickly mention that we're going to do a hands-on course in collaboration with SDI, and I know Adrian from SDI will talk to you a little bit more about this. It's October 4th in Chicago. So if you're interested, we'd love to have you. And once again, I want to thank you so much for spending part of your evening with me. It means a lot to me that we had 157 participants. Amazing. So let me take a minute to answer some questions here.
Adrian here. Would you like me? I've got some questions here that I can read off the prompter to help you out a little bit.
Yeah, that'd be great.
Yeah, so one of the questions here is, in the case of the hypocalcification on the centrals that you did you just remove the affected enamel and replace that with composite or veneer the total buccal surface?
This is the case that was 6 units, I'm assuming.
It was the hypocalcification.
Yes. Okay.
Just past the halfway mark, yeah.
Yeah, there were 2 hypocalcification cases, but the second one that we did 6 units, we actually just we just kind of overlaid composite over that. We did not prep anything away. It was pretty amazing.
Okay, there's another question there around tetracycline. So the question is, how does bleaching react with tetracycline staining in your experience, and what are the expected results?
So it often takes several visits, and it's a conversation that I like to have with patients and say, we may get some improvement and lighten up, but we will definitely not be able to eliminate that, because especially with the case like the one that I showed, there's such a gradient. If it's a really mild tetracycline stain, then we see results. But I'm often doing the bleaching as just like a first step to the next thing, which is oftentimes chairside composites or something in ceramics. So bleaching alone usually doesn't do the trick, especially when it's severe. Do you have a few more questions, Adrian?
Actually, that's all that was there, I think.
Okay, I see a few here. Do you find that nano CR, as I'm assuming nanocomposite resin, to restore incisal edges tend to wear and chip more frequently than when using a more filled CR? In my experience, no, I haven't found that. And oftentimes, the chipping could be an occlusion issue. And so you definitely want to address the occlusion. And certainly if you think that a night guard is warranted, I would advise the patient that you'd want them to protect their restorations. But I personally have not seen that nanos fracture more. And then the next is, what is my polishing protocol? So unfortunately, we don't have time to cover all about composites in this 1 hour. I like to use spirals. So I know that Ultradent makes a spiral. Brasseler makes a spiral. There's like a slightly coarser than a fine spiral. It's like a silicone spiral. I love to use those. And to get my line angles and outlines, I like to use Super Snap discs by Shofu. And then they have a 1 glass point or some kind of pointy stone to define my my lobes and my depressions. So this, with anterior maxillary, with centrals, it's always 3 lobes, 2 depressions. And so my polishing protocol tries to follow that. So again, spirals first, and then discs, but never a disc on the surface. We don't want to flatten our anatomy, and then stones after that. And then a final diamond polishing paste with like a buff of some sort. And then I want to be mindful of your time. Please confirm if the hygienist should not polish those composites. My hygienist polished all of my composites all day long. I should probably talk to them, about it, but it doesn't make a difference. They polish them. We use a Profi jet. So if you know what a Profi jet is, it's actually, kind of spraying those with a very low abrasive powder and air and water pressure, and I've not seen any issues with that. It's more than anything is, looking out for coffee stains and things like that. Any good veneers course you recommend? So if you mean chairside composite veneers, I know that Dr. Marshall Hanson has an amazing series of courses. And if you're looking for ceramic veneers courses, actually, Dr. Tom Dudney does one in Alabama, I think, and he's actually through Catapult Education. And then I actually have taken one by Maxim Belograd in Prague. He's terrific. And then we're doing our little mini course in October, so something to consider. Can you share a bit about your AACD accreditation process? Absolutely. More than actually getting accredited, and this sounds very cliche, but it really was the process of getting there. It changed my way of seeing things in dentistry and just aesthetics as a whole. If you start trying to do the accreditation process, there's so much more that's going on that allows you to become a better clinician. You want to get 5 different cases. You first take a written exam, and then you do your case submission. You start doing different. So there's like class 4. There is a 6 direct chairside composite case that you have to do, along with an implant, and then 2 indirect ceramic cases, so 5 total, and then a final in-person oral exam. So I would encourage everyone, if it's something that you're interested in, you really would gain from even just trying to do the accreditation process. I mean, if accreditation isn't your end goal is just kind of learning the parameters, it's so worth it. Do I always use glycerin in the last polymerization? Yes, absolutely. I don't use glycerin, but it's a whole lot less expensive. I actually use like a prepackaged material that helps, with the air inhibited layer. But I think it's fantastic if you can save some money and use glycerin instead of something that's already prepackaged as a dental material. Do you do most of your composite veneers as no prep veneers? I try to. Yes, I absolutely try to. If I need to prep, then it's likely going to be a ceramic case. And if the patient needs ortho beforehand to minimize or eliminate my prepping, then I do a lot of clear aligners in my office, and especially before some of these composite cases. So it's really nice because you can set up the case so that you have the most conservative outcome. So yes, I try not to prep. Do you do cutback? Do you only do cutback when you do injection molding? No. So so 2 different ways to do chairside composite veneers, and there's probably more than 2 different ways, but 2 different ways that I do it. You could layer in your effects. So you could do your clear layer and then your dentin lobes, and then you put in your tints right at that point, and then layer on top of that. Or you could, I know Marshall Hansen does, like he builds up and then he always does a cutback. So it really is your preference. I think that once you get proficient in one way and you have a preference, then you want to do it that way. And if the patient, doesn't have a lot of translucency going on, then you certainly don't need to cut back. And again, the patient's usually happier long before I am. So no, I don't always do cutback on every case, but when I do, there's a reason for it. When using a mylar strip, you mentioned it's not necessary to finish the composite after removing the mylar strip right at the gingival margin only. Isn't that necessary to remove the O2 barrier layer to get a full composite set? That's a great question. I don't like to touch I put my my deox, whatever I'm going to use, and cure again at the gingiva. But I don't like to put a burr to the margin, where the composite meets the resin, like right at that pre-gingival margin. I don't like to prep there if I can avoid it. Thank you again, everybody. I hope you learned something.